Hey, good afternoon, everyone. Thank you all for joining us today. Christy Degner and I are the site engagement coordinators for the Michigan Value Collaborative, and we look forward to facilitating today's diabetes work group. Today's presenters are guest presentations from Brenda Gleason and Carli Kundinger from Scheurer Health. Brenda has been a nurse for 40 years in various roles. Brenda loves nursing for many reasons, including the ability to change your role without ever having to leave the field and the endless learning opportunities. She has worn many hats in her career, from a burn unit and critical care nurse all the way up to a director of nursing and administrator for a nursing home. Her more recent work in diabetes care includes functioning as a diabetic educator for 4 years and is now a registered nurse care coordinator. What she loves the most about nursing is the patients and helping them to achieve their health goals and improve their overall quality of life. Carli is also joining us today, and Carli has been a registered dietitian for 6 years. During her time as a registered dietitian, she has worked with a variety of people, from educating children at school to monitoring residents in long-term care and caring for inpatients in the hospital. Carli loves that she can have all the variation in just one job. However, her passion is in education and supporting people, specifically with diabetes. She became a certified diabetes care and education specialist in 2020 and is currently an educator for the quality coordinator for diabetes education program at Scheurer Health. What she likes most about being a registered dietitian and certified diabetes care and education specialist is being able to give people knowledge of nutrition and about their disease. Carli finds that giving people knowledge often provides them with the motivation and power to make their own choices to live healthier and happier. And by sharing this information, we hope that Carli and Brenda are able to provide our other members with motivation and power to influence their diabetes education programs. So thank you, Brenda and Carli, for joining us today for the work group. You're welcome to prep your slides, and before I transition over to you for your presentation, I'm just going to go over some brief housekeeping items. As a reminder, this session is being recorded. The slides and the recording will be shared with attendees after the work group concludes. We will be monitoring the chat throughout the presentation, so feel free to add questions as they arise, or you're welcome to ask them at the end as well. And then lastly, for MVC, your feedback is very important to us, and we appreciate all of the feedback you can provide for our work groups and other engagement opportunities. So we ask that you please complete the post work group survey. The link will be provided following the conclusion, along with the link to the recording and the presentation deck. So with that, I am going to stop sharing my screen and pass it over to Carli and Brenda. You are welcome to share your presentation, and I will monitor the chat for questions. Thank you again.
Okay.
Looks great.
Okay, and you can hear me okay, right?
Yes. Yep.
So our presentation today is going to be about how diabetes education and care management work well together. I'm Brenda Gleason, and thank you, Chelsea, for that wonderful introduction. So a little bit about Scheurer Health. Next slide, please. Scheurer Health is located in the tip of the thumb of Michigan. We're a rural health community, and our healthcare network includes 5 clinic feeds into the hospital. This is some of the patient improvements we've seen working together. Our average A1Cs for patients in May of 2021 to May of 2022, the average was 7.1. And then working together in developing our program further, we saw that in April of 2022 to April of 2023, our A1C averages declined to 6.7. Care management and diabetic education, actually, when it comes to our diabetic patients, share the same goals. Our goals is to educate patients to self-manage their diabetes, and we like to help them lower their A1C to less than 7, and support the patient. What we do is support the patient in achieving these goals. As a care manager, the way I connect with patients is Epic, our EMR, we use Epic. We can run reports with patients that have an A1C that's higher than 7. And then I do some chart review into that, and I have a conversation with the provider discussing if they are a good candidate to hand off to care management. Whenever possible, if I'm in the clinic, the provider will do a soft handoff where he introduces me to the patient, but he also introduces care management and what to expect from care management. And then I'll set them up for the initial face-to-face appointment where we do more goal setting, we do more assessments, gathering information and looking at resources that they would need. So when we're setting goals, we're looking at larger goals and smaller goals. A larger goal might be to lower the A1C, lose weight, improve lifestyle habits. And we also look at the smaller goals to support the larger goals. That could be, not that diabetic education is small or any of these, but they're excellent tools to help the patient reach their larger goal. It could include diabetic education, a continuous glucose monitor, typically always lifestyle changes. We like to work on lowering carb intake with our diabetic patients. So we look at low carb diets and then get the patient resources. We educate the patient, and I spend a lot of time communicating also with the patient's PCP on needs and the progress that they're making. So ways that I connect with the patient is I'm always in connection with them monthly, and that's either face-to-face or by telephone or a virtual visit, depending on the patient and their needs at that time. If the A1C is greater than 7, the patient that has the continuous glucose monitor, I will see that person in a monthly appointment, and I'll use that report from the continuous glucose monitor to support the education that they're getting. If it's below 7.0, I follow up with them monthly on the telephone. We always look at the goal progress, discussing how we're progressing and giving them positive feedback, looking at barriers and brainstorming ways to overcome those barriers so we can meet their goals. I also educate and refer on as needed. Go ahead.
Okay, this is Carli talking now. So the key times to refer to diabetes education would be like at the diagnosis, at least once a year or whenever they're struggling to meet their glucose goals. If new complicating factors arise, or any life changes. So this is typically any of these reasons would be while Brenda or the primary doctor would refer the patient to me. So getting the patients into the door, the diabetes order usually comes from the physician, or it always comes from the physician. A lot of the times, the care manager, Brenda, she will identify that need during her sessions and send the request to the physician and let them know they could benefit from diabetes education. And so then the provider would then put in the order. The office staff from the primary care office staff usually just calls and schedules the patient for the patient instead of relying on the patient to make that phone call. Oftentimes if a patient makes the phone call or says they want to make the phone call themselves, it kind of becomes an unscheduled order. And when that happens, I personally call them. That way I can answer any questions, explain the program, and get them scheduled. And along that same lines, if a patient, they have an initial appointment, but they cancel it or they miss it, and it's not rescheduled, I'm the one that calls them. So I personally call them. And again, I ask them if they have any questions or concerns about attending the program, and I try and get them scheduled. And then I would also let the care manager know that the person hasn't scheduled, so that way they can encourage them whenever they're making their visits. During the initial appointment with diabetes education, we go over an assessment and we make a diabetes plan. During that initial appointment, we will start to work on that plan. So whatever education areas that we identify that they need, we will start that in the initial appointment. And then schedule a follow-up appointment as needed. We would then follow up. I follow up with the primary doctor and the care manager as I need regarding the patient. So if something comes up in my appointment that I think needs to be addressed or reinforced by Brenda, I send her a message and let her know that, so that way she can make a note and talk to the patient about that the next time she talks to them. And then we have the completion of diabetes education. So once we have finished our plan that we made at the initial appointment, that is considered the completion of the diabetes education. We can change the plan throughout if we need to. And if they do complete, they can always come back, but we have to have a completion date. And that's something that's required for our accreditation. So once they do complete, they will be following with their care manager again if they're already in it, or if they don't have a care manager and I think they need it, then I will let the doctor and the care manager know that. And then when the care manager is following up with them, they can refer back to diabetes education as they need. Okay, so I have found that the way that the primary doctor and the care managers present diabetes education or talk about diabetes education to the patient makes a huge difference in the patient's willingness to come and their desire to be there. So just with them communicating the importance of diabetes education, making it a part of their diabetes plan, and following up with the patient, like if they attended, if they got a lot out of it, or if they needed more, and then they can relay that information to me as well. Okay, so our diabetes program is accredited by the Michigan Department of Health and Human Services, and we're accredited by the Association of Diabetes Care and Education Specialists. So with the accreditation, we're required to have an assessment, a plan, interventions, and a completion date. And all of the education is individualized to each patient. So like starting with the assessment, we will identify the patient's concerns, and we will identify the areas that they need addressed by me. So sometimes they are the same, sometimes the patient might be concerned about something totally different, and that needs to be addressed as well as what I have seen in their assessment that needs to be addressed. So then we would make a plan, and we set this up with the patient. The patient is part of making that plan, and that's important. The plan includes what education we're going to go over, like what topics we're going to go over, the number of visits that we're going to have, how we're going to connect. We do mostly it's in person, and honestly, I prefer in person. It's a lot easier to connect with patients on a personal level if it's in person, for me anyways. But we do offer virtual, and for CMS, we're required to offer the virtual first, and if the patient can't, for whatever reason, do the virtual, then we can do a telephone, a telehealth appointment, but we are required to offer the virtual first. So then we do the interventions, and that's all based on the plan that we made at the first appointment. And we can change that plan based on the changes that are going on with the patient, like at different follow-ups, if the plan can change. But we do have to have a completion date, and that's something that is set by the accreditation organizations. So we have a completion date, and then I kind of assess, like, do they need to have care management? Do they need additional help? So I will like I said, I'll let the nurse, the care manager and the doctor know that if I think they need it. If they don't have care management, and they don't really need it, I will follow up with them 3 to 6 months after they complete, just to see how they are doing and see if they need to start the diabetes education again. So we really try to incorporate the CGM if it's possible. We offer a professional CGM. So if the patient isn't able to access isn't able to have their insurance cover a personal CGM, we can put on just a professional one, which will last 10 to 14 days, depending on which CGM it is. And we find that this really helps the patient make the information more relatable to them. So it helps us assess how the patient's doing. But the patient seems to be more engaged in learning whenever they can see, like, oh, Carli was saying this, and I'm pointing at, like, their blood sugar, looking at the screen where there's other CGM data, and I'm explaining why this might have happened. They can remember it a lot better, and they want to learn that information a lot better. And oftentimes it makes them want to come back to have a follow-up with me to see their progress on that. The CGM also helps us identify areas that we might not have noticed before, such as, like, in the middle of the night, what's going on, and if something needs to be changed. So the patient is always the center of our care. Yeah. So it's diabetes education, the care manager, physician. The patient is always the center. So then when we look at the keys to success, again, the patient is the center of the care. We are constantly aiming for the patient to be able to self-manage. We communicate as a team. So we have an open line of communication with each other. We're not scared to send a message and let each other know what's going on. We read each other's notes, which is something that can be a problem with some
Care providers.
care providers, thank you. And then the CGM we have found is very pivotal because it really helps the patient. They feel like they're more of a part of what's going on whenever they're able to see their blood sugar at that moment in time, whenever they want to look at it. Okay.
Do you have questions?
Any questions for Brenda and Carli?
If not, I'd be more than happy to share a success story or two.
Yes, please. I have some questions, but I would love to hear your success stories.
Okay. Most recently, I had a patient text me yesterday with A1C results from yesterday. But when this patient came to me, he had an A1C greater than 12. And I was able to get the proper tools for him. He attended some diabetic education. I was able to, his insurance was covered for a continuous glucose monitor. We got him on the medicines that he needed to be on. I think that the provider put him on an SGLT. No, he put him on a GLP-1. And he started taking the medicines and he started meeting with me monthly. Having 5 clinics, I have the ability to go to any clinic I want. Carli is hospital-based, so I was able to go to a clinic closer to where he lived. And he would come in and see me monthly and we would review that report together. I would give him some more educational tools. Pretty soon he started having hypoglycemic events. So he was calling me and I said, okay, I will talk to your physician right now and I will have him back off on some of your medicines. So we ended up getting, he's off of all of his insulin. He's off of his glipizide. I think the only thing he takes anymore is metformin, and he's learned so much about his diet and his activity that as of yesterday, his A1C was 5.8.
That's amazing.
Yes.
I'm curious, on average, how many appointments would you say each patient has like in their program? It probably varies based on, their start and end A1C and any potential cancellations in between.
For the diabetes appointments.
Yeah.
It really depends on the patient. Mostly it's 2 to 3 appointments. But there are some that I will see monthly. Like if they're not seeing a care manager. Sometimes patients aren't able to, their insurance doesn't cover a care manager for whatever reason. So they will just see me monthly. And that it is required to have a completion date. So I kind of put that in the plan that we're going to have so many appointments. And I don't usually do it for like 12 months. I'll usually do like 3 and then we'll start like a new plan.
Now, as a care manager, and I will see them as long as they need to, but it's not necessarily face-to-face. Like I said, once they get down to the A1C of 7, I keep in contact on a monthly basis on the phone, and it might be a 5-minute call, it might be a 30-minute call, depending on their needs at that time. They know they can always contact me. When they reach their goals and have been there for a while, then I start to back off. I might call them every other month. I might call them once a quarter. but by still being in contact, they know they have that support as long as they need it. So I have found that they're able to maintain, like this gentleman that texted me yesterday has actually been off the program for 3 months. So I find that they maintain their success with their goals if I stay in touch with them a little bit longer.
Definitely. There was a question in the chat if you're able to share approximately how long the time frame was of the patient whose A1C went down from 12 to 5.8.
Actually, it was about 7 or 8 months that while he went from the 12 to 6 range, 6.5 in 7 to 8 months. And then I continued. So I think what I'm going to get is I'm going to get quarterly progress from this guy. I'm still maintaining. So I still give him the way to go. I'm so proud of you.
That's great. Yeah. Karen agrees. That's wonderful. Have you observed any changes to, follow up with patients or maintenance following the completion of their programs based on the type of appointments they held, like if they were virtual or face-to-face? Has there been any noticeable difference for patients, like if they're more likely to continue a program or maintain following the completion of their program if they do in person versus virtual?
I haven't seen it. I haven't noticed a difference.
I haven't noticed a difference either.
And patients do have my office phone has a direct line. So they do have my direct office phone. So like they can leave me messages and I still talk to them. If they call me, I can talk to them. If it needs to be an appointment, I will tell them that. But if they have like a quick question or something, I'll answer that over the phone without having an appointment scheduled. So some patients that might have completed the program, 3 months from now, they might have just one question and they give me a call and they ask it and I answer it, and then they're still willing to contact me.
So Chelsea, the one thing I have found virtual versus in person is the building of trust, because really they need to know I care. Yeah, they can see that virtually, but not necessarily telephonic. So I find that one face-to-face appointment so they can get to know me very important, because they build that relationship with me. I try never to rush them through that appointment, and they value the relationship and they value the knowledge they get. I let the patient dictate. Do you want to do this telephonic? Do you want to do this face-to-face? I have a group of people that they definitely want to do it face-to-face every time.
Yeah. I've only had a few people that have had the initial appointment as virtual. And they usually just want to do the one appointment and that's all.
Interesting. Yeah. Those are very interesting observations.
But if they see me face to face and then there's a reason that they can't come, transportation or something, then I find that they follow with me just the same.
That's great. I mean, speaking of, transportation issues, have you noticed any challenges for patients, particularly with follow-up and getting to their appointments? Do you know if there's resources to patients for issues like that?
Yeah, so in Huron County, in the tip of the thumb, we do have what's called as the Thumb Area Transit bus system, so they can call and schedule it to go from their house to their appointments. Some patients that use that, they do call and cancel like the day of or the day before, that for whatever reason their bus schedule the pickup or drop off time got changed, or they forgot to schedule it. and that type of thing. So there are some transportation issues.
As a care manager, that's something that's one of the barriers I try to address. Just because they go to diabetic education, I don't back away from it. So if it's a care management patient, Carli would be more than happy to let me know that there's transportation issues, and I would try to get them the resources so they can make their appointments.
That's excellent. Christy, I have two other questions, but I don't want to overshadow anything that you have to say. Do you have any questions?
You're okay. Go ahead.
Okay. Are there support persons that are also educated in the sessions with patients, family members, friends, caregivers that can participate with patients to support them in their care plan?
Yeah, for diabetes education, if I actually prefer them to come with somebody else, it's 4 ears listening instead of 2. A significant other might catch something that I said that the patient didn't realize. So yeah, I usually recommend it. They seem to learn a little bit more, and they might tell on each other too. They're more honest sometimes whenever they have somebody sitting next to them. And also for the patient isn't always the person that administers the insulin or makes the meal. So it is important that they're there as well. Like if recently I had somebody, it was a patient and her husband and her daughter, because her daughter helped make the pill pack, put the pills in there, and the husband was making the meals. So it was good that there was actually 2 people that came with her instead of just her.
We actually do encourage a team approach, so they know that they don't have to go through this alone.
Yeah.
And diabetes doesn't just affect the patient, it affects their family and the community around them.
Yeah. And
Very true.
yeah, I would consider their family to be part of our team.
Mhm.
Yeah, that I think that goes back to the patient-centered medical home and whole health that we've focused on, and a lot of our members have focused on. That's great. I have one other question. Let's see, Marjorie, do you ever recommend bariatric surgery for type 2 diabetics?
I have not recommended it. I do know I have worked with one provider who was looking at that option, and the patient has decided not to go that way. I will say I am currently working with a post-bariatric patient. He had bariatric surgery, I think about 3 or 4 years ago, maybe even longer than that. And actually diabetic prior, and now we're having problems with hypoglycemia all the time. So I am actually reaching out to a bariatric specialist to see what I can do, because we have a hard time. It's important to me, as well as Carli, that we get rid of the hypoglycemic events first. And we're having problems here. So this is a challenge, and it's a learning opportunity for all of us.
Yeah, and I guess to answer your question, I don't recommend it to the patient, but if they come in and they're planning to do it, I will support them or help them learn what they need to know for that. But I don't bring it up to the patient and start the conversation with them.
I would look at lifestyle changes first.
Yeah.
That's true. Marjorie said that they believe Blue Cross Blue Shield now covers bariatric surgery as a treatment option for BMIs of 30 to 35. Did not know that.
I didn't know that either.
Yeah.
Very interesting.
which is fine. And it'll work as long as the lifestyle changes go
Yeah.
along with it.
Yeah, so I guess that's what I meant whenever I say I'll help them with it. I want to teach them eat afterwards as well.
Yes, yeah, especially with those hypoglycemic episodes, that can be really scary for a patient and a
Mhm.
caregiver, family member. Makes it difficult to do day-to-day life. I know. I
Mhm.
know someone with that in my life, and it's risky to drive. It makes, your daily
Yes.
living activities a risk.
Yes.
So, that's important. Apparently it was a very recent announcement by Blue Cross. Thank you for sharing that.
Okay.
Are there any other questions for Carli and Brenda?
I have one question for you. Just going back to kind of diabetes management medications, with the increasing kind of demand and popularity for some of those weight loss medications and type 2 diabetes medications, does that change your diabetes education practice at all? Have you noticed that more patients are taking those medications? Are there access issues with those medications like Ozempic, Wegovy, and
So there are
metformin?
some access issues, and it's specifically dependent on the dosage that they're on. Like with the Wegovy, which is the weight loss, it's the lower doses. The Ozempic, it's the higher doses, one of the higher maintenance doses. But there's reasons for them to be put on it, and it's for their cardiovascular and kidney health function. So I'm supportive of them and see improvements and see that they're able to get off of other medications. As long as, again, I'm going to be a preacher on this, as long as I see the lifestyle changes too. If they're going to take the Wegovy for weight loss and not make any lifestyle changes, they'll either be on it for life, or they will gain the weight back once they stop if we don't do lifestyle changes with it. And through continuous contact with me, they have a good understanding with that. That was a good question. Thank you.
Yeah, thanks for answering.
My last question, so I feel like I consumed the conversation. I appreciate your responses. Do you have in mind the average time to treatment or first consultation with you for diabetes education following the initial physician's order?
It's usually 2 weeks. We can get them in earlier if it's more of an urgent need, but it's usually 2 weeks that we will schedule them for.
Thank you. Okay. Any other questions?
I saw one
Oh,
pop up, but I wasn't able to
there we
read
go.
it.
Yes, this class of drugs do need to be discontinued 7 to 10 days before an anesthetic. Okay, so prior to surgery. That is good information. Thank you, Steve. Kieran asked if you ever do group education, for example, even cooking classes.
Okay. So before COVID, we had the group classes. We haven't really had them since because we're in such a small area. People are driving farther. It's harder to get them all in one place at one time. So we haven't had the group diabetes education. We have had, so not specifically for diabetes. Our hospital network has a community wellness department, and they do exercise classes, and they have like a weight loss fit challenge. And for that, I will do a cooking class, and that twice a year. And so it's not just diabetes patients, but I do see a lot of my, diabetes patients at the cooking class.
That's fantastic. I worked with a critical access hospital. Actually, they weren't, I don't think they were critical access, but they were a safety net. They were a safety net hospital. So they did have a lot of more at-risk patients and populations than other hospitals in their area. And that's one thing they offered was nutrition courses, cooking courses, low impact healthy activities classes, and that was a key interest of the diabetic patients who sought care at their facility. So I think those are fantastic offerings for patients and help get to the other aspects of healthcare that maybe not all clinicians can, treat. Excellent. Any others? Okay. Well, on that note, thank you both again for presenting today and for participating in our discussion and answering all of the questions. I'm going to pull up the closing slides for the work group today. Thank you, Brenda and Carli. Our upcoming events, for those who are interested in at the MVC, we have a preoperative testing work group coming up on August 1st, where we will have Nick Berlin, who is from the University of Michigan Department of Surgery, presenting. On August 9th, we have MVC's inaugural rural health meeting. This will be 10 a.m. to 12 p.m. online virtually with guest presenters Ross Ramsey from Scheurer Health and Mariah Hesse from the Michigan Critical Access Hospital Quality Network. And then coming up at the end of August, on August 24th, we will have a health equity work group with presenters Janae Tias from the Greater Flint Health Coalition. We welcome you to join us for those. The registration links will be available in the presentation that's going to be sent out at the end of the work group today. And just wanted to say thank you again to Carli and Brenda and all of you who attended and participated in today's discussion. We look forward to seeing you at future work groups and other engagement opportunities. And if you have any questions, you're always welcome to email us. I hope you all have a great rest of your day and a great rest of your week. Thank you. Bye.
Thank you.